Janindra Warusawithana, who's working in London, UK. And so it is known, there's no need to introduce Mr. Janindra Warusawithana. He's a renowned consultant colorectal surgeon, a trainer, and a researcher. He has trained many Sri Lankan colorectal surgeons who are acting as gastrointestinal surgeons and who are members in our society. And Janindra has the special interest in inflammatory bowel disease, intestinal rehabilitation, pelvic floor surgery, and colorectal cancer. Without taking further time, I'll hand over the podium to Dr. Janindra.
Thank you very much, and I apologize that I've had to change your schedule a little bit, but I have to run the European board exams very shortly, and I was just juggling my time. So it was very nice to spend some time with you guys earlier in the UK time this morning, and now I'll spend some time again talking about short bowel syndrome and how we manage it, and some of the future perspectives, or certainly how we look at the whole concept. When we deal with short bowel syndrome, there are a few things we need to think about. The first thing is we need to think about how we prevent situations where where we actually develop short bowel syndrome, especially in emergency situations. Then there's an in-between period, and that is probably one of the hardest things, because it creates a general sense of nervousness both for the patients as well as for the clinicians. And trying to manage that whole situation can be quite different. And then we get to the reconstruction phase. So I'm hoping that we will be able to go through the whole thing quite good. Now, I think when we come to prevention, I think the best thing to think about is that prevention is much better than cure, and we know that. And when you don't have a cure, you have to make sure that you don't make it any worse for yourself. So if we are to sort of try to think about how we look at the whole concept of dealing with short bowel syndrome, we need to look at certain messages. The first one is avoid that temptation for looking for a second, third, fourth, fifth time. Certainly not after 10 days. What happens is that once you start to go after 10 days and head towards the 14 days, you start to get to a situation where you get a lot of inflammatory reaction. The bowel is very fragile, and everything you touch will just fall apart. It's almost like trying to deal with something incredibly fragile. People say, oh, you better have a look, have another look. Maybe there's a bit of ischemia, maybe there's a hole, maybe there's this. Don't do it. And the most important thing is to have damage control, not damage creation. You then end up with a patient in an intensive care. You've got radiologists, anesthetists, intensivists, surgeons. Everybody has a different opinion. For us, the biggest one is the intensivist. So, oh, you know, something's a little bit wrong here. The blood pressure's dropping a little bit. You better do another laparotomy. And I think it's really important that you have the conversations about why you don't want to do it, not just say we're not going to do it. And the main issue is you have to be very, very rational about why you have to do it. It's not to say that there aren't certain times when you might have to do it, but those are very rare. The second thing we have to think about as surgeons is our psychology and how we relate to decision making. Because the moment something goes wrong, say for example, you have a patient and you have an anastomotic leak or something like that, you might end up in a situation where you feel you need to keep fixing the problem, and then you've got an unconscious patient or a sick patient in intensive care, and their family might come and say, oh, what have you done? Why is this not being fixed? This one's not getting better, and so on and so forth. So you go through this cycle, if you like, whereby you end up wanting to fix the position and you keep going on and on and on. So what the concept treats us, or how we sort of deal with it, is we want to sort out the problem, try and repair the anastomotic leaks, close the abdominal wall, starve the patient till any fistulas have healed. And that's probably not the way I would say you should look at it. The realistic treatment goals from my perspective is, don't make the problem any worse. Try and divert any sepsis or leak. That could be radiological or surgical drainages. Don't be afraid of leaving an open abdomen. And where possible, you need to have enteral nutrition. And the whole thing is to keep calm and to do damage control. So um, there is very limited role for things like strictureplasties and all of that sort of stuff, and so on and so forth. So what to do when it all goes wrong? Avoid the temptation for multiple laparotomies. What's the benefit of relooking and do damage control? And remember that fear is only a temporary thing, and regret is what lasts forever. So this is how we approach prevention. We avoid the anastomosis in malnourished patients in the presence of ischemia or next to active sepsis. We close it with care. Don't use non-absorbable mesh, especially when the bowel is very friable. Don't use vac pumps directly onto the bowel. And as I said to you, especially after 2 weeks and certainly up to 6 months, don't reoperate on these patients. We then come to the in-between period, and the in-between period is quite hard because the in-between period is where we need to look at the nutrition of the patient, but also they're going to have problems which they don't want. It could be a stoma, it could be a fistula, and it could be all of these things. And as a surgeon, it's important to have your nutrition team, your gastroenterology nutrition team, but also you need to talk about things like, this is what we are going to do. And you've got to explain to the patient things like why you want to wait your 6 months. There are certain things we need to consider: sepsis, and where possible, use radiological drainages as much as possible to drain the sepsis. Understand the anatomy, understand what's going wrong, where are the problems. Maintain nutrition. If possible, enteral nutrition is great, even in the presence of fistulas. But if you can't, you might need to combine the two together as well. And then build your patient up. This is where you get them to do exercise and electrolytes. So a typical referral for our intestinal failure unit here at St. Mark's is they've been in hospital for months, they've had multiple laparotomies, their fistula has been repaired and relook operations done, they've been made nil by mouth, they've been in bed, depressed, liver function tests are abnormal, repeated line infections, and they've got pockets of sepsis, and they can look like this. This is a terrible situation to try and reconstruct a patient. So what we do, we let them eat if they can. Don't make them starve. And if the gut can be used, definitely use it. Also remember that albumin is not a marker of pure nutrition. Giving parenteral nutrition is not going to improve albumin. You have to know that something else is wrong. So if you have a patient with Crohn's, for example, they may have a lot of inflammation and that's why the albumin is low. It might be that they have sepsis and that's why the albumin is low. So we let them eat, get them out of bed, get psychological antidepressant support, get some of the medical bits sorted out, drain any sepsis, and stomach care is really important, and try and get them home. So these are sort of, this is not obviously a short bowel syndrome patient, but just to point out that you can use your radiologist to drain sepsis. And the other important thing is, these are the things that are really going to upset your patients as you wait, you know, when they have skin conditions related to their stoma. So have very, very good specialist wound, stoma, and fistula nursing. Here you can see a patient who is only managing with dressings here, but you can see how much skin is actually damaged or burnt as a result of this fistula that I'm pointing out here. And again, with really good stoma care, you can actually bring that skin much better, and the patient's going to feel better. Distal feeding is really important, and it means that your distal gut is able to be in a better stage when you join things together, and you get faster return of bowel function. And again, the next thing is, don't let your patients drink more just because they have a high output stoma. If they have a high a stoma or a fistula, they will have high output. What you need is to give them loperamide or codeine, omeprazole, and fluid restrict them, and give other fluids instead of water. So what you really need is things like diorolite, which is what we use, maybe something like Givini or something where your sodium concentration is incredibly high. Give them lots of salt, which is what reabsorbs the water back into the gut. And then as you're keeping your patient, you need to know what you're going to deal with, because your next step is to actually build up your bowel, or to reconstruct the whole thing. So you need to plan the procedure in advance. And as time goes on, you will notice that your bowel loops are going to start prolapsing. And when they start to prolapse, that is when you know that things are starting to get better inside, and your adhesions are starting to improve inside as well. So you can see here the fistula is starting to prolapse. And then you do a very good reconstruction, build it all together, and close it down. How you deal with it will depend very much on what approach it is, and you really don't have much of a choice. Sometimes you have to take away some of that skin and so on and so forth and bring it all together. And it might mean that you might have areas that are broken down, but those are not going to be major problems, although you have to remember that your patients are going to get stressed out, because the first thing they're going to think about when your skin breaks down is that the entire problem is going to start again. Remember also, and you have to tell these to your patients, that the rate of intracutaneous fistula is about 82% healing. So even in specialist centers, some of those can recur. And based on that, it's okay to bring out a high output stoma and plan a further operation if you need to. But you have to remember that these patients have enough mental anguish, and it may be too much for them. So having conversations and dealing with them is really important. And finally, this is really important as well. It's really important to measure the length of remaining bowel, and to actually tell the patient how much bowel they have remaining, especially in the Crohn's patients in particular, because it is really, really important that they understand how much bowel they have left. Because if they have centimeters or 85 centimeters, and that is helpful for you as a clinician as well. In the Crohn's patients, you have to be careful about what you join. If you have sepsis or abscess, lower albumin, where they're on steroids, as I said before. If you have a fistula at the time of surgery, when you start to have these risks, your risks of anastomotic leak is high, so be aware of those. And then you come to postoperative management. Don't fluid overload. Don't do enhanced recovery. Have a very strict fluid balance. Restart them on their parenteral nutrition, because they'll have a long ileus or fear of eating. Mobilize them early and monitor their albumin and CRP. So this goes back to having patients who've had small bowel ischemia, who have very low, very short bowel, and we looked at some of our series here, and you can see that if you restore them very early, they have a very high rate of anastomotic leak, whereas if you restore them later, the anastomotic leak rate is low. But the important thing is having, even if you have low residual small bowel, if you have some degree of colon, it is very important to join them. And as time goes on, you can see that if you restore them to their colon, even with short bowel, their need for parenteral nutrition goes down. So that's really important as well. And we had more than 70% of patients at 5 years who basically stop their parenteral nutrition. And it's irrespective of having less than 50 centimeters of small bowel, they don't get very bad diarrhea because the colon adapts very, very beautifully. So I think you've got to have a very, very standardized approach to intestinal failure and short bowel. You've got to make sure that there is restoration of continuity. It's important and associated with gut adaptation over the long term. There are some newer techniques like expanding the small bowel or trying to make things larger, like the Bianchi technique, for example, but they have a lot of complications and they're still in their infancy. We are actually looking at things like trying to develop scaffolding and so on and so forth, but I think that's some time away. And but there are different approaches as well. So once again, thank you very much for your listening to me, and I will happily answer any questions you have.
Thank you, Janindra.